Welcome to the North Carolina College of Resuscitation. I'm Jamie Jollis. I'm a cardiologist at Duke University. Along with thousands of colleagues in North Carolina, we're all working to improve emergency cardiac care.
I'm Chris Granger. I'm a cardiologist at Duke University, and I'd like to welcome you to this series of presentations on a very important project for the state of North Carolina. That is the Heart Rescue Project, or RACE CARS. And this is the project to improve survival for patients with cardiac arrest by 50% over 5 years in the state of North Carolina. And it has a series of proven interventions that we need your help with, that include interventions in the community to increase rates of bystander CPR and to educate the public to activate the EMS system when a cardiac arrest is identified. It involves the best practices by emergency medical services, including rapid application of defibrillation and best care in transportation and destination to the best centers able to care for patients with cardiac arrest, and then hospital measures that include primary PCI when that's indicated, therapeutic hypothermia, and best care for patients with cardiac arrest during their hospital phase, including consideration for implantable defibrillators. And by doing all of these things, we believe that we can be very successful in improving survival for patients with cardiac arrest.
Okay, let's talk about emergency medical dispatch, improving outcomes by wire. So as you can see, there's a long list of activities that may go on with this person. This is a bit of a riddle to decide who this may be. And it encompasses lots of different tasks that are occurring simultaneously. Computer entry, talking to multiple agencies, talking to multiple callers. So who do you think this person may be? That's a dispatcher. And what do we have in North Carolina as far as dispatch capabilities? There's a certain degree of variability within North Carolina, but about 70% of counties employ emergency medical dispatch. And of those counties, many employ computer-aided dispatch or they utilize the card system. But what about those counties that don't utilize emergency medical dispatch? Many have local written protocols, but most do not give pre-arrival instructions. As far as dispatch training goes, historically it's basically been on-the-job training, but of late, especially with the advent of emergency medical dispatch, national programs and national certifications exist. There's state training, and most incorporate CPR training, although CPR training is not mandatory with EMD programs. Does North Carolina have a standard? So North Carolina does have a standard, but only in terms of emergency medical dispatch. It does not mandate that emergency medical dispatch be offered. And we think this would likely be helpful. So in questioning a 911 caller, there's basically 3 questions that need to be asked. First question is determining the chief complaint from the caller. And the second is identifying information and the location of the emergency. And then to determine if the patient is in cardiac arrest. Next will follow an example of an actual call. After you listen to this, think about the things that you would do differently.
Emergency, this police, fire, medical.
This is medical. My wife, I think, she met right here yesterday, and I think she's having another attack or something.
Okay, what's the address?
1-8.
Is she conscious?
Yeah, but she's making a lot of noise and stuff, but she's out of it, it seems.
How old is she?
She's 75.
And what were they out there for yesterday?
Yeah, the same one. Seems like she'd have a, I don't know, she's not coherent. I heard her just moaning right now. I just got up.
Okay, is she able to talk to you at all?
No, it doesn't seem that way.
Have you tried to talk to her?
Yeah. Yeah,
Does she look at...
She's moaning right now.
Okay, does she look at you when you talk to her?
Yeah, she looked, but she's staring like in space.
And so you went to the doctor yesterday. Did they tell you what happened? What was wrong?
She had a stroke, I believe.
Yesterday?
Low sugar, yes.
Okay, low blood sugar isn't the same thing as a stroke.
Well, I'm not sure what she's got now.
Okay, but what did they tell you yesterday?
Well, her low blood sugar.
Okay.
That's what it was yesterday.
Has she eaten this morning?
Not this morning, no.
Is she insulin dependent?
Yes. she's making all kinds of weird noises. I'm not sure what, I don't know what to do. Yeah, she's making, right now she is.
Can you test her blood sugar?
No, I can't right now. I don't know what to do. She's not...
Okay, do you know how to test her blood sugar?
Yes, but I can't get to her now. She's, just, I can't get, she's moaning and everything else.
Okay, and what is your name?
My name...
Getting help en route. What I want you to do, if you can take her blood sugar before they can get there, that would
Right, but I don't think I can.
Okay, that would be very helpful if you can.
Okay.
Nothing, I don't want you to put anything in her mouth unless she can actually hold on to something and take it herself. And if she can...
Yes, ma'am.
Okay, if something changes with her before they can get there, I want you to call right back.
Okay.
All right?
Thank you.
Seattle's experience uses two questions. Is the patient conscious, and is the patient breathing normally? So why do we ask first if the patient is conscious? Well, that represents a fork in the road. If the patient is conscious, we certainly won't move to CPR instructions. And the second question, is the patient breathing normally? If the patient is breathing normally, that will lead us to another fork, whether the patient is unconscious and breathing normally, or if the patient is conscious and not breathing normally. But why don't we ask if the patient is conscious? Well, it's difficult sometimes to decide about consciousness, and there's multiple questions that can be asked following that. Is the patient able to talk to you? Does the patient respond to you when you call his name? Does he move or flinch? So there are multiple questions that can be asked to determine what consciousness actually means to that caller. So in interrogating callers, if the person is unconscious, ask, is the person breathing normally? But what is breathing normally? If unsure, ask if the patient's chest is rising and falling. If the caller is unable to report this, then simply move on to CPR instructions, or if the caller is unsure. Agonal respirations, which would be termed ineffective or abnormal breathing. It's usually described as slow and passive and typically irregular. The chest doesn't rise in a rhythmic manner. But agonal breathing is also often mistaken by the caller as breathing. Agonal breathing is described in a variety of ways: barely breathing, breathing occasionally, grunting, snorting, groaning. So the caller may describe this in multiple ways. So again, if the patient is unconscious and not breathing normally, it requires an immediate basic life support and advanced life support response. Inform that caller to stay on the line, dispatch the appropriate units, and let the caller know that help has been dispatched. If the patient is unconscious but breathing normally, again, have that caller remain on the line, dispatch both basic life support and advanced life support. Remind them that help is on the way, and then proceed to your unconscious and breathing normal algorithms. There are certain situations where CPR may not be offered. Basically, they involve trauma. A blunt traumatic arrest, we would not offer CPR instructions. However, certain traumatic arrests would require CPR instructions. Those that typically would involve hypoxia or asphyxiation, such as hanging, strangulation or drowning, and even electrocution. Certainly where signs of obvious death have occurred and there are signs that are incompatible with life, or if there's a danger to the rescuer. What are the delays in delivering CPR by EMD? Well, research shows several questions are involved, and one, it's the unnecessary questions that are asked, or the bystanders not near the patient. One of the most important, though, is the omission of, is the patient breathing normally, and deviation from standard protocols. How old is the patient? Does the patient have a heart history? Duplication of questions. What is the patient experiencing? This is an experience from Amsterdam, where they took 506 emergency calls, which represented about 3% of their overall call volume. And they realized that unrecognized cardiac arrest by the dispatcher resulted in almost 1 full minute delay in dispatching of the emergency vehicles, and then almost 1.5 minutes of extra response time before actually providers arrived. The main culprit in not being able to recognize if cardiac arrest has occurred by the dispatcher was not asking the question, is the patient breathing normally? And you can see 42 out of 82 questions, this is what occurred. It's more than half. If you'll pay attention to the graph on the right, you'll notice that the top line is recognition by the dispatcher of cardiac arrest, and the bottom line, which is dotted, is the failure of the dispatcher to recognize cardiac arrest. And then you can see that survivability actually increases as the graph goes up. So there's a dramatic difference in survival compared to the dispatcher who recognizes cardiac arrest compared to when cardiac arrest is not recognized. If the patient is not conscious and not breathing, normally do we really need to know about his medical history? Certainly if he doesn't have medical history yesterday, he definitely has medical history now. All we need to know is the patient is dead. We need to offer CPR without delay and inform the caller that help is on the way. Listen to the following example.
Emergency police paramedic. Is he conscious? No, he's not conscious. Is he breathing normally? Well, maybe his head back to his airway. Is he breathing normally? No, not really. Okay, then you need to get him out of the vehicle and lay him flat on his back because it sounds like we need to start CPR. Just get him flat on his back and kneel beside him.
Okay, and you want to chest impression only?
Yes, hands in the center of his chest, right between the nipples. Put the other hand on top of that. Press down firmly with the heels of your hands about an inch. And what I want you to do is do it 50 times, 50, and count out loud.
Got it.
Do like 1, 2, 3, 4.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18.
Okay, well, if his chest isn't going up and down and it's really slow, just go ahead and keep with the CPR, okay?
Okay.
Is that the patient?
Yeah, he sounds like he's gargling on something.
Yeah, that sounds like he's got agonal breathing. Keep doing the chest compressions only, okay? No, is that 911
okay.
on the phone?
I'm on it.
Make sure.
Should we institute dispatcher-assisted CPR, and why should we? Well, the numbers vary, but somewhere between 250,000 to 500,000 people suffer cardiac arrest in the United States each year. And this is a picture of Safeco Field in Seattle, when we could fill that stadium over 4 times each year with the number of people who die in the United States. How often is bystander CPR performed? Folks probably think a lot. It's much less than we may think. Nationally, about 25%. In 2010, Bo Brow published this study in the Journal of American Medical Association. And you can see the title, Chest Compression Only, CPR by Lay Rescuers and Survival from Out-of-Hospital Cardiac Arrest. We can look at this experience from Arizona, and you can see a dramatic difference that occurred over a 5-year period. In 2005, 20% received bystander CPR, or 1 in 5. By 2009, 75% of cardiac arrest victims had bystander CPR performed, so 3 out of 4. You can look at the graph A and see that all comers, this is everyone who suffered an out-of-hospital cardiac arrest regardless of presenting rhythm. At the bottom you see standard CPR and compression-only CPR. In this group, standard CPR resulted in an 8% survival rate, and these folks were discharged alive from the hospital. In the group that had only compression-only CPR, 13% survived. Graph B, we look at witnessed or shockable rhythms such as ventricular fibrillation or ventricular tachycardia. In these groups that received standard CPR, almost 18% were discharged alive from the hospital, and in the compression only, almost 34%. Time is critical. For every minute that treatment is delayed, the chance of survival decreases by 10%. What is dispatcher-assisted CPR? First, it's efficient and effective call handling. It's immediate recognition of cardiac arrest. It's rapid dispatch of basic life support units, quickly determining the location of public access automated external defibrillators, and the rapid dispatch of advanced life support units. But it's also assisting in the quick and efficient delivery of CPR instructions to the caller. What encompasses the typical dispatch-assisted CPR program? Things that you would ordinarily find in other programs. First, planning, well-written protocols, which at this point are nationally standardized, training, quality improvement, and then continuing education. Key points to dispatch-assisted CPR. Average EMS response times in the United States vary between 4 and 6 minutes. Dispatchers can help begin CPR by bystanders in less than 1 minute in many cases. Early CPR increases the chance of patient survival, can nearly double the rate of bystander-assisted CPR, and has become the nationally recognized standard of care. Where does EMD fit in the chain of survival? First, let's look at the chain of survival. Number 1, access to 911. Number 2, CPR. Number 3, defibrillation. Number 4, ALS. And number 5, integrated post-resuscitation cardiac care. It's easy to argue that we know that link 1 certainly encompasses the emergency medical dispatcher, but many could argue that the first 3 steps actually encompass emergency medical dispatch with the advent of public access automated external defibrillators. But let's look at links 1 and 2 in the chain of survival. And challenges to CPR by bystanders. Cardiac arrest, number 1, it's hard to identify, especially by the lay public. It's also difficult to identify over the phone. Bystanders lack confidence to act. CPR can be technically difficult. Dispatchers should instruct untrained lay rescuers to perform hands-only CPR for adults who are unresponsive with no breathing or with abnormal breathing. Basic questions to ask in instruction. Does anyone there know CPR? Many bystanders may be trained but still may require or desire instruction. Get the phone next to the victim and the bystander. Listen carefully. Let the bystander know that you will offer them instructions on every step and stay with them until help arrives. Chest compression only CPR. We know that bystanders are much more willing to perform compression only CPR for a variety of reasons. Many victims may have regurgitated, which would prevent most bystanders in performing mouth to mouth. Typical CPR actually may cause regurgitation, which may cause a bystander to stop CPR. We also know that studies have shown us that in the typical adult primary cardiac arrest victim, it takes about 10 to 15 minutes for their arterial blood oxygen to desaturate below 80%. So in that first 10 minutes of a primary cardiac arrest, oxygen is just not as important as we've always thought. And therefore, we should concentrate on hands-only compression CPR to move that blood and oxygen to the brain and the heart. Rescue breathing interrupts chest compressions. If you look at the graphs on the right, you can see that graph A lists compressions only, and graph B has compressions with interspersed breathing. Which one do you think provides more compressions? We know that the compression fraction actually increases the chance of survival. That is the number of compressions that actually occur during a CPR event. Graph A absolutely shows more compressions being performed than graph B. Barriers to dispatcher-assisted CPR. There are many barriers that exist to this, most of which are dogma, and many of which are concerns by the dispatchers in time management. We're not able to provide CPR instructions because we're overwhelmed with other duties, or they're worried about their increase in liability. Dispatcher and automated external defibrillators. So what is an AED? Automated external defibrillator device. Basically, it's a portable device that is able to recognize a life-threatening rhythm and then able to deliver a defibrillation or an electrical shock. That basically depolarizes the heart or stops the heart and then allows the intrinsic pacemaker to take over and create an organized rhythm. The most typical life-threatening arrhythmia that we face is ventricular fibrillation. It's a chaotic, disorganized beating of the heart that's not able to produce adequate blood flow to sustain life. Here you see an actual AED, and the device is fairly simple. You can see that it's actually listed in steps 1, 2, and 3. Step 1, turn the machine on. Step 2 is where your rhythm analysis occurs in either voice or printed instruction. Step 3 is the button that delivers the shock or defibrillation. Steps in using an AED. First, we've got to locate that AED. So be cognizant where AEDs are located in your workplace, and if there's not one located in your workplace, strive to have one located there. Once you find it, open the door and then follow the prompts. Turn the machine on, place the pads. The pads actually have the position that you place on the patient on the pad itself, and then connect the pad to the device. Most devices show a picture of where the pad actually plugs into the device itself. Then the machine will automatically analyze the rhythm, and it will tell you if a shock is indicated or not, and then you simply follow the instructions of the device. If it tells you to shock, you push the button that says shock. Current use of AEDs. In North Carolina, EMT defibrillation is the standard of care. But currently, few bystanders actually employ AEDs. And that's unfortunate because the AED was actually designed for the lay rescuer. In North Carolina, currently less than 2% of all cardiac arrests have an AED utilized by a bystander. Frequently asked questions. Can I harm the patient? No. We can only harm the patient if we don't act. In 2009, a study was published in Seattle, Washington that showed 247 people were given CPR instructions by the dispatcher where EMS found that cardiac arrest had not occurred. Of that population of 247, only 6 people succumbed to injury, and those were basically trivial or insignificant injuries. Should dispatchers be trained in CPR? Yes, it's much easier for a dispatcher to give instructions when they're technically competent with the technique. It's not necessary that they be trained as EMTs, but certainly in CPR. The caller doesn't want to perform CPR. While we certainly don't want to force or make a caller feel guilty about not performing CPR, it's important that we inform that caller that we're going to stay with them step by step and give them instructions throughout the maneuver until help arrives, which should make them much more receptive to actually performing CPR. Caller knows CPR and is doing it. That's fine, allow them to continue, but also offer advice and help, especially with counting, or if they get stuck and need further advice, let them know that you're going to be there to help them through the process. The dispatcher feels bad if the patient dies. The dispatcher is a part of the EMS system just as much as the EMT or the paramedic, and should have the support of their colleagues and supervisors just as all those folks who respond to medical emergencies. Cannot get the patient into position for CPR. This happens frequently, and if the caller is unable to position the patient in the correct position, that's what we must deal with. We should instruct the caller to open the airway and then remain with the patient until first responders arrive. Most die. Why all the work? While in the United States the chance of survival from out-of-hospital cardiac arrest is about 5%, in some counties and communities in the United States, almost 50% are discharged alive from the hospital. So I would argue that most die is incorrect. Why do all the work? Most people have died historically because we haven't done the appropriate work. As you can see, this is a slide from the operations manual of the RAISE project, and it goes through some sequential steps that the dispatcher should ask. One, is the patient able to talk or conscious? Is the patient able to breathe, or is he breathing normally? The dispatcher should immediately recognize if cardiac arrest has occurred, and then dispatch appropriate units and also offer CPR advice or instruction. And then after CPR instruction or during CPR instruction, the dispatcher should give advice on the utilization of an AED if available, and also prompt the caller if there is an AED near their location. Quality improvement in EMD. Quality improvement. Probably the most important aspect of quality improvement for EMD is response times. Lots of people play games with response times and how we define them. Many agencies define as when the call is dispatched and the unit begins the wheels rolling until that unit arrives on scene. We would actually argue that the response time begins when the first ring to the 911 center occurs and ends when that responder is at the side of the patient. That's probably the most important response time we have, because we know time being critical, every minute that passes, the chance of survivability goes down by 10%. So in looking from a quality improvement standpoint, we should really look at this as a team effort from the dispatcher, the responding units, and quite honestly all the way through the hospital. But more importantly for that response time, look at all those barriers that increase delays, such as call centers that have to transfer one call to another, the caller being placed on hold, lack of recognition of CPR. All those things increase our response times and thereby decrease the patient's chance of survival. So in summary, the EMD represents a vital component to a successful outcome in cardiac arrest. recognition of cardiac arrest by the dispatcher and immediate dispatch of advanced life support and advanced life support providers, knowledge and coordination of those public access automated external defibrillators, and then dispatch-assisted CPR increases bystander CPR and thereby will increase our survival in North Carolina.